Good afternoon and welcome to today's presentation, Substance Abuse and Dependence Update. To give you a little background about our presenter, Dr. Andrew Farah, he's a board-certified practicing psychiatrist and a distinguished fellow of the American Psychiatric Association. He is the medical director and chief of psychiatry at High Point Division of UNC Healthcare. Dr. Farah is also an assistant clinical faculty member of High Point University, Division of PA Studies, and is a nationally known researcher, educator, and clinician. He is also experienced in deposition and courtroom settings. His latest book, Hemingway's Brain, is due out in 2017 by University of South Carolina Press. Attendees who require a passcode, the word for today is update. During the Q&A session, we will ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log on to your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list to the left of your screen. Thank you all for attending today, and Dr. Farah, the presentation is now turned over to you.
Great. Well, thank you, Naja. Thanks for joining us, everybody. So as Naja said, I'm Andrew Farah. I'm Chief of Psychiatry at the High Point Division of UNC Healthcare. Though I'm off campus, I'm not on the main campus of UNC. The day of national mourning, of course, is filtered over to us after the Villanova win last night. So everybody's trying to comfort themselves with the news, of course, that Duke was bounced out much earlier, so that made everyone happy. There is one slight change on the slide. I do list my extension there, but since I wrote these slides, my correct extension in the hospital has changed to 2150 or 2150, so the old extension doesn't work. Just wanted you to have that correction. So thanks so much. We'll go to slide 8, which basically just is our outline today. We're going to talk about all sorts of drugs of abuse, intox, detox, social issues, cultural issues, and legal issues. Of course, we're going to start with marijuana and something called spice, which, of course, is a shorthand for the synthetic cannabinoids, synthesized a very long time ago. Then bath salts, which, of course, are not bath salts. Fortunately, the use of that has gone down thanks to law enforcement efforts. Of course, cocaine and methamphetamine and the stimulants, we're talking about those. Opiates, including heroin, we're going to cover that. Suboxone and methadone, of course, will be covered, as well as the benzodiazepines. This is the class of agents that include Valium and Xanax and Klonopin and Ativan, those types of sedative hypnotics. And we'll talk about the fact they're very dangerous in combination with the opiates. That's a very prominent cause of accidental death when people mix their benzodiazepines and opiates. And, of course, alcohol and alcoholism, will cover that. And then there's this whole miscellaneous category, people that inhale things, people that take fentanyl patches and cut them open, and people who drop acid and so forth. So there's a whole variety of other things. It's kind of curious. People figure out ways to abuse things that would never cross my mind. So there are hospital concerns that come up. There are detox concerns. Nothing ruins a social or family structure like severe chemical dependency. And there are different philosophies of treatment. You know, there's this is not one size fits all, and there are certainly some controversies regarding treatment. And of course, relapse rates are very high. And of course, you're all legal folks, so we're going to cover some legal issues. So that's our basic roadmap of where we're heading today. So slide 9 is titled Introductory Topics and Comorbidities. You know, the chemical dependency population is very, very challenging because there are many illnesses we describe as illnesses of relapse, but this one is very, very much known for the highest relapse rate of many of the things we treat. For example, alcoholics who go through detox and rehab and are even going to meetings, the relapse rate within 4 years, 90% have relapsed. And it would probably be higher if you count the sort of one-time binge or something like that. So as far as needing more treatment. So it's not uncommon to meet patients who've been in and out of treatment, sort of like a revolving door. A recent study, it was from 2010, looked at heroin addicts in particular and other opiate addicts. And these are folks who went through an inpatient detox and an inpatient rehab. And 91% had relapsed by the time that the clinicians caught up with them within 6 months. And in fact, 59% relapsed within 1 week of being discharged from the facility. So not very good odds there. One of the more curious aspects of that study was that going home to a partner who was still abusing and or dependent on an opiate or heroin, that actually delayed the time to relapse. Perhaps these partners came home and saw what it was doing to their loved one, and they weren't going to jump right back in that boat. But that was very curious, I thought. So when we do our discharge planning, of course, we always ask patients, where are you going home to? Who's there? Do they use? And so forth. So one of the things that predicted a high relapse chance was, of course, being younger and using higher doses of heroin prior to coming in. But again, these are just some of the really challenging issues. And we know that depression and chemical dependency, when you see CD, that's a shorthand for chemical dependency, by the way. Depression and chemical dependency, of course, are very comorbid, and it becomes a chicken and egg argument. Are they drinking too much because they're depressed? The drinking leads to depression and so forth. And I think you just obviously have to treat both, of course. And we know that suicide is highly influenced by chemical dependency. For example, when you look at all the cases of completed suicide, alcohol or a sedative hypnotic like Valium or Xanax or Ativan or something like that is present in 61% of the cases. So 61% of the time, somebody's impaired at the point that they take their life. There's a curious statistic about suicide that says women attempt suicide 2 or 3 times more often than men do, but men succeed twice as often as women do. And the truth is that women tend to overdose, which, thanks to a new generation of antidepressants, is a fairly safe thing to do nowadays, to overdose on antidepressants, unlike about 30 or 40 years ago. But men tend to use more violent means, such as shooting themselves or hanging themselves, cutting their wrists and so forth. So that this curious discrepancy, women attempting 2 or 3 times more often, men succeeding twice as often, actually it's flat even if you take away substance abuse. So if you look at people who attempt or complete suicide when they're sober, then the rates are 50-50 male-female. So that was a very interesting influence there of the chemical dependency. We know that schizophrenics, 80% of the time when I admit a schizophrenic to the hospital, they're admitted because they're non-compliant with their medication. No surprise there. They have an illness of psychosis, an illness of a form of thought disorder. And I had a schizophrenic this morning on rounds arguing with me that there was absolutely nothing wrong with him, never mind the fact that the police had sort of dragged him in and he was violent and so forth. He didn't think he had an illness, you see. But 55% of the time when a schizophrenic's admitted to the hospital, they have a drug screen positive for something illegal, usually cocaine or marijuana, or at least alcohol, but of course that's not illegal. It's very common to have a comorbid substance abuse issue with schizophrenia. Patients with personality disorders, the borderline personality disorders are sort of prone to that self-destructive behavior, have a higher chance of substance abuse. And then again, there are things called substance-induced mood disorders, fairly old term now, because now the new DSM makes you sort of specify it. But, there's some folks, for example, I had a colleague refer me a patient. I do mostly hospital work. And he said, you've got to put this young lady in the hospital. She has rapid cycling bipolar disorder. So we put her in the hospital, and she had no access to cocaine, and her rapid cycling bipolar symptoms went away. So many psychiatric illnesses are mimicked by substance intoxication, withdrawal, internet use, and so forth. And I learned very early in my career when patients are telling me a story and it just doesn't make sense, or their clinical presentation just simply doesn't add up, that usually I'm dealing with an issue of chemical dependency. Okay, so the last bullet point on slide 9 just talks about these comorbidity of violence and substance abuse. It may surprise people to learn that 58% of the people arrested in Chicago have a drug screen positive for marijuana. They have marijuana in their system at the point of arrest. And the low in the big cities is Atlanta. Only 37% of arrestees in Atlanta are under the influence of marijuana, so don't let anybody tell you that it's a calming agent. So now we're going to go to a fun slide, slide 10. And this just speaks to some of the issues of drug use in popular culture. You've all seen this. I hope you haven't seen Reefer Madness' movie. It's a horrible movie, but it's become a cult classic. It was actually made between 1936 and 1939 as sort of a morality tale, stay away from drugs. But it was sort of rediscovered in the 70s and became this sort of goofy cult classic. And there were pieces of truth in it, the idea that marijuana can induce psychosis and so forth. To me, the next big movie that sort of changed the culture was probably Blow Up, the Antonioni film with David Hemmings and Vanessa Redgrave. Fantastic movie where he's basically a fashion photographer who accidentally photographs a murder that Miss Redgrave is tangled up in. But what was culturally different about it and what it sort of changed the direction of culture was sort of the first movie to show the sort of the mod scene in the swinging London of the 60s, but there was this use of drugs that was just sort of open, and it wasn't, it was in this culture, it was thought to be just sort of cool and hip and that sort of thing. So it was sort of the first mainstream movie to just show it out there. Fascinating, fascinating movie if you haven't seen it. My favorite part, there's actually a cameo with the Yardbirds. They're playing in a sort of a bar scene, and as Jimmy Page and Jeff Beck are up there playing. So it's kind of a fantastic movie if you're a music buff. So of course, not long after that, the Yardbirds split up, and Jimmy Page is going to make what he calls the new Yardbirds. So you all know that story. Of course, he was Keith Moon of The Who came over to talk to him about his new band, and when he told him about his idea, Keith Moon suggested that his new band would fly like a Led Zeppelin. So, of course, that became the name of the, not the New Yardbirds, but became Led Zeppelin, and the rest is history. So I think each member of Zeppelin is now worth about $80 million, the surviving members. So, anyway, so now we come to slide 11. And, of course, marijuana has long been sort of a counterculture identity drug, very commonly used, commonly obtained, sadly. And there's this sort of cultural perception that it's safe and it should be legal and all that silliness. In 2013, the number of people surveyed over age 12 who said that they had used marijuana within the month was 7.5%. That's up from 5.8% as recently as 2009. But its acute effects include some paranoia. Some people do get very paranoid and agitated on it. They can become apathetic, depressed, either euphoric. So it can kind of go all over the map. There are cannabinoid receptors all over the brain. Panic and depersonalization, derealization. The depersonalization is a psychiatric term, and it's sort of like this persistent deja vu feeling where patients will say, I don't feel like myself. I don't feel like things are real. They may say, I feel like I'm floating outside my body. I feel like I'm in a movie. I feel like things are not real. And marijuana will affect the NMDA receptors. Long story short is they're receptors in the brain that help mediate what we call associative processes, the here and now. Where are you? Where are you going? What are you doing? And how connected to you are you to your surroundings? Or are you dissociated from your surroundings? You're in a fugue state. Are you in an amnestic state? That sort of thing. So the reality is that patients who abuse marijuana, there's particularly the high potency forms and the synthetic forms are at very high risk for this sense of depersonalization and derealization where things just don't feel right and it can be a permanent induction. So as odd as that sounds, that they may use a high potency marijuana one time and have months and months of this sort of persistent derealization, depersonalization, and be diagnosed actually with depersonalization disorder. Now, the longer-term effects, of course, include the emotional blunting and apathy and depression. And there are 33% of people, as many as, you've seen estimates from 9%, I've seen as high as 33% of people are physically dependent on it and go through withdrawal syndrome without marijuana. But as far as this idea, does it actually cause people to lose IQ points? And there have been studies that showed a drop in IQ points up to 10 points per decade of dependency, particularly the adolescent brain. And there was a wonderful study as far as the methodology goes. They followed people up to age 38, took thousands of people, and basically did a long-term epidemiological study where they established different points in time marijuana dependence and use and measured them on all sorts of neurocognitive batteries. And sure enough, the folks that were dependent on marijuana did indeed have a significant decline in their cognitive functioning. We know that when used in adolescence, it alters white matter connectivity. What is white matter connectivity? Well, that's basically the connection between the white matter of the brain cells. And that's thought to account for the cognitive dulling and the loss of IQ points. And MRI scans of daily users show that their brains actually atrophy. What else is that? Dementia of the Alzheimer's type shows atrophy. The areas of the brain that atrophy the most are the amygdala and hippocampus. They have the high concentration of cannabinoid receptors. And that's where your memory is housed, So that the temporal lobes, so very important for memory and processing. They also have done some unique studies with PET scans showing just some diffuse alterations in metabolism, decreased metabolism in the daily user. And further, there seems to be some studies showing this plasticity of the CNS vessel, the brain vessels lose some of their integrity with daily use. So again, don't let anyone tell you this is a harmless compound. It's a terrible compound. There is no specific detox for it. And a lot of my colleagues, if they see a patient with a drug screen positive for marijuana, they just say, well, it's part of, the culture. And they do not disqualify that patient from receiving a prescription for Xanax or Valium or pain pills or stimulants even. And I'm the opposite. I think if you have a drug screen for something illegal or something that should be illegal, my opinion is that you're not a candidate then for Schedule II medications. And you need to be off of that before I put other psychoactive compounds in your brain. I know that's controversial with some of my colleagues, but if somebody has a dirty drug screen, they don't get Schedule II drugs in our clinic. I'll tell you this case on slide 12. This was a young man just out of college who had new onset paranoia, manic symptoms. It was clear that he was a bipolar. Comes in the hospital. He'd been abusing marijuana and, of course, alcohol was in his system. And we were able to, get him stable on an antipsychotic and a mood stabilizer. And I said, for goodness sakes, don't go back and use this garbage. Go to rehab, so forth. But he continued to use, and the continual use of marijuana just basically counteracted what we were doing with the prescription drugs. And he became this sort of non-compliant, treatment-resistant individual who actually had a very sad outcome. He got into a scuffle and actually got shot. But he, it was just one of those terrible. He did survive that, but he, it was just one of those terrible stories where you saw this young, bright man, and you just saw his brain kind of deteriorating, and it was all due to this sort of, substance-induced pathology that we could not recapture. Slide 13 is very important. It discusses this link between marijuana and psychosis. If you're in a college area, schizophrenia sort of presents in college age 18 to 22. So it's not uncommon to admit 2 or 3 of these kids a month who come in with first break psychosis. And you do a drug screen and they have marijuana in their system. Now, we'll go into that. Now, schizophrenia is a lifelong illness. It's probably 80% from genetic causes. It's, of course, highly heritable, right? But the bottom line is that it's an illness of hallucinations, delusions, disorganized thought, disorganized behavior. And it's again, about a third of these schizophrenics do terrible. They wind up in homeless shelters. They wind up in jails or prisons. About a third come in and out of the hospital lifelong, but are managed. And about a third actually hold down jobs and do pretty well. So it can be a terrible diagnosis, of course. And 1 out of 100 people, 1% of our population is schizophrenic. Now, I mentioned it's genetic, but there's a genetic risk there. And like many illnesses, there's this combination of genetic risk and environmental influence. So, for example, I unfortunately inherited the genetics for heart disease, but I exercise a good bit, and I eat right, and all that sort of stuff. Married a vegetarian, so there's no red meat, that sort of thing. So hopefully I won't get heart disease. But if you you do some things that are environmentally going to put you at risk, and the genes are there, the genetic risk is there, then you have illness. We know that that schizophrenia is an illness of dopamine excess. Too much dopamine, you can't metabolize your dopamine effectively, or you're producing too much. And COMT was the enzyme that metabolizes dopamine. So 15% of schizophrenics have got a particular phenotype for this particular gene, and marijuana interacts with that expression of that gene and forever alters that expression. And now, for that 15% of the population, they will use marijuana, and they will use it repeatedly. That will cause a genetic change in their brains, and now they have a schizophrenic illness. Now, since I wrote this slide, there's other genes involved. The AKT1 gene, there's probably multiple genes, but the reason the COMT gene kind of stood out was that we accept in psychiatry that people that become dependent on marijuana in their adolescent years are really playing Russian roulette, that 15 out of 100 of them will show up with schizophrenia within the next 4 years. And so that seemed to be the exact percentage of people that had that particular genetic risk. And it's been estimated that we would lower the rate of schizophrenia by 8% if we would just make marijuana abstinence a priority. So again, don't let people tell you this is safe and should be legal. The slide 14 is it's kind of the more science behind what I was saying. THC is the main toxin in tetrahydrocannabinoid, right? That's the main cannabis, the main toxin of cannabis abuse. So before the 1990s, if Timothy Leary were here, he was using a marijuana that had 3% THC and something called cannabidiol in it, 3% cannabidiol. Now, the important thing about cannabidiol is it actually blocks the dopamine receptor so that it perhaps would have an antipsychotic effect. And when people have isolated out cannabidiol, they realize that in small trials, people with schizophrenia actually get better on isolated cannabidiol because it acts like an antipsychotic. Now, the problem now is that the new strains are more than 18, sometimes 20% THC and 0% cannabidiol. So the natural protective in the plant has been bred away. And that's why you didn't see the rates of schizophrenia and psychosis with marijuana use in the 70s and 80s, but you do going beyond 1990. So again, the one part of the compound that people would claim is medicinal is no longer in the plant. So what is spice? So we're going to slide 15. So we move from the natural marijuana to the synthetic cannabinoids. And again, these are not plants. What these are, they're test tube created cannabinoids that are sprayed on various herbs. And so they look like, just like herbs that are crushed up or marijuana or something, but they basically been sprayed with these basically cannabinoids that were synthesized as early as the 1940s. People were synthesizing cannabinoids, and they're very, very potent. They have much higher binding affinities at the cannabinoid receptor than THC. So when I was saying that the potency of these marijuana plants at 20% THC, well, these synthetics, if you go to the next slide, it looks rather complicated, but it's actually simple if you think about it. You have marijuana, upper left THC in the plant, and when we talk about binding affinities where a molecule hits a receptor in the brain, how potently it does it, how tightly it does it, how little a concentration it takes to cause an effect to bind, those are called a Ki value. So the lower the Ki value, the more potent, the higher binding affinity there is, and the more dangerous that synthetic will be. So that you can see these very synthetics are sometimes, multiple times more potent at the cannabinoid 1 and cannabinoid 2 receptor. In fact, some of them I didn't list are 1,000 times more potent. That's why the people that have used spice are more prone to this cannabinoid-induced schizophrenia, cannabinoid-induced psychosis, and disorganized behavior and thought. Slide 17 elaborates that people have actually had seizures, psychosis on spice, and myocardial infarction. And we don't always pick it up in our drug screens, so you may not know what's going on. And again, as I mentioned, there's 85 toxins in the marijuana plant. But of course, the first one we mentioned was THC, the second is cannabidiol. And again, the spice ones are simply not going to have cannabidiol. Much more dangerous. So slide 18 describes the bath salts. And this is not a bath additive, although they are packaged to look like Epsom salts so that they can get around the laws. It seemed to start in Europe. It started in England in particular. And these have been around for a very long time. These were synthesized gosh, I think over 100 years ago, and they were recently sort of rediscovered. The reality is that, I think it was synthesized about in the 1920s. That's one of my notes. That is, it's a synthetic cathinone, which is naturally, that's a cathinone's naturally found in the cotton plant, so you know the natives who chew the cotton and so forth. But the stimulant effects are much like being on an amphetamine. But it also, it affects all neurotransmitters in the brain. So they can give people hallucinations, euphoria, but again, disorganized thought and behavior. Slide 19 elaborates further. But yes, there it is. 100 years ago, they were synthesized. The dopamine in the brain, the norepinephrine in the brain, and serotonin in the brain, it prevents their reuptake, causes them to flood the neurotransmitters. So you basically get this derangement of the transmission system in the brain that regulates mood and behavior and thoughts and energy and so forth. So these people are quite disorganized. I remember one young man that he was case one is the 26-year-old male who had been admitted more than once, and usually the police would bring him in, and he was a high-functioning individual, had a good job and everything. I said, why in the world are you doing this? He goes, well, I just kind of like to hallucinate. I said, boy, I can't help you with that. I'm not the guy to make you hallucinate. I'm the guy to take them away. But he was really just a bright fellow who just, for some reason, was seeking that bizarre high of just the arrangement of the senses. So the real problem is that there's no specific detox. We just have to keep them calm until the storm passes. We use high-dose lorazepam. We use sometimes phenobarbital, which also will help prevent seizures. And many of these folks do need antipsychotics as well before they're stable. And so the question on slide 20 is, do these bath salts induce permanent psychosis? You've all heard about the case in Miami where they called the cannibal case and so forth, suspected of being on bath salts. What was in that individual system was actually marijuana, but again, you never know which assay they were using or what else might have been there that evaded the drug screen. But I did a chart review of our last 12 admissions with psychosis induced by bath salt ingestion. Four of them I just could not catch up with. They never came back to our clinic or the referring clinic, and they were just lost. But four of them did resolve, and they had no further, as long as they stayed drug-free, they had no further psychosis. And the final four were developed a psychotic disorder, and they are now on antipsychotics. So, that estimate of 25 to 50% is probably about right as far as do these induce a permanent alteration of brain chemistry and create psychosis. So we have slide 21, which just shows some cultural images that you can identify readily as associated with slide 22. Of course, cocaine. And cocaine went from the expensive powdered drug to the very cheap cracked form, because crack form is much easier to smuggle in and sell and distribute. It's just such a highly concentrated as opposed to the baggies of the white powder and so forth. One of the problems we have with substance abuse is when they mix cocaine and alcohol together, it causes something called copoethylene in the blood, which makes people violent. And it does prolong the high, but that compound is associated with more violence, arrests, and so forth. Of course, the acute effects are fascinating with cocaine because, of course, you have the euphoria. It can hit people right away within 5 minutes. It can last up to an hour and a half. There's two interesting stories. There's a patient who was talking about his first experience with cocaine. And he said that somebody gave it to him and he tried it. He says, I don't feel anything. I don't feel particularly good or bad. It just didn't do anything for me. 20 minutes later, he went back and said, you got any more of that stuff? And he described perfectly that this drug can induce a craving for itself, whether or not you have a euphoria. So it's an interesting twist that there are some drugs like Xanax that will upregulate receptors after just one dose and make your body request more of it. The second is a fairly common joke in the chemical dependency world. It's about a man, a cocaine addict who rubs the bottle and the genie comes out. He says, you get 3 wishes. And the addict says, I want a line of cocaine that never runs out. The genie says, okay, there it is. Well, what are your other 2 wishes? He goes, I want 2 more lines just like that one. So sometimes the appetite is insatiable. Acutely, the effects. It can also cause a form of movement disorder, akathisia, very heightened restlessness and agitation. It's hard to treat. That is fortunately temporary in the vast majority of people. So they generally come in the hospital after their binge, and they have the crash phase where they're irritable and sleep all day, and they're hungry, and they say, "Leave me alone. I'm not going to groups." And they're unpleasant for 3 or 4 days, and they get up and they're craving, and they leave. We can often help the craving with something called amantadine, sort of an old drug that's been used for Parkinson's and is used as an antiviral, but for some reason it helps on dopamine receptors and it helps with cravings. Baclofen is a old muscle relaxant that also may reduce cocaine cravings in individuals. So those are a couple of tricks we have up our sleeve for patients who can't stay clean. So Naja, I think we have a question slide now, don't we?
Yes, we do, Dr. Farah. If everyone could chat in the Q&A the passcode for today, that'd be perfect. Our first question is from Arthur, and it says, I had some courses in the early 80s on the subject, and the psychiatrist teaching one of the courses mentioned heroin had a recidivist rate of over 90%. As it does not seem much has changed, is there any reason to believe any progress will be made in the next 30 years?
Yeah, it's a good question. These illnesses come with very high relapse rates. So, we are always looking for ways to help people stay sober, stay relapse-free. So there's a host of things in the pipeline that work on the craving area, the dopamine receptor, the reward mechanism that may reduce cravings. We're farther along with the alcohol than we are with the opiates. And then there's also the Revia or naltrexone, which blocks the opiate receptors, so that that's sort of a way, as long as people take that, then they take the opiate and take the heroin, it doesn't have an effect. The dangers are, of course, they could still keep trying to take it and overdose on it, even though they're not feeling the high from it. And of course, if they stop taking the anti-craving or blocking drug, then it's only as good as their motivation to take it. So you're right. Ever since we've been told chemical dependency in the realm of psychiatry and gotten it away from general medicine, we've had a hard time. And patients have had a hard time. This is an illness of frequent relapse. So, but again, all I can tell you is to specific to your question. Yes, there are agents in the pipeline that are trying to. People are trying hard to reduce cravings and relapse going forward. And even you're right. Even with the best of programs, it's an illness of relapse. We'll talk about the opiates in a bit and go into that specific.
Okay, before I ask this next question, I see that people are chatting in that they didn't get the passcode. And since we were having technical issues, I will let you know that the passcode is update. So if you could type that in now, that'd be perfect. The next question is, does casual use of marijuana decrease IQ or only dependence?
Yes. Most of the literature we have is in adolescent users who are adolescent daily users, because the adolescent brain is the one where the white matter connectivity is and so forth. The large study that I told you about, there were adult users who did see a drop in cognitive scores in multiple domains, and they were not adolescent users, but adult users. So yes, it does have that effect, but not nearly, it's only 20% or 30% of what you would see with the adolescent user. So it can happen in adults. And again, it's also dependent upon the potency and the strain and so forth. And but again, the folks at most danger for cognitive issues, and in particular schizophrenia, are the adolescent daily users.
Can you clarify the risk of schizophrenia with marijuana use?
Yes, we know that the estimates range from 10 to 15% of our schizophrenic population would never have been schizophrenic if they just stayed away from marijuana. So they had the genetic risk in their system. And that environmental stressor on that genetics is classic, what we call epigenetics. When the environment changes the expression of a gene or a collection of genes to express an illness, that was cannabis, that was the THC. So we think the first spiel I did about the CMT gene, maybe that's a factor. It's maybe the AKT1 gene and a cluster of other genes. But that's basically it. That if you look at our population of schizophrenics, sadly, that 10 or 15 out of every 100 would never have been schizophrenic if they had just never used marijuana, and particularly the marijuana-dependent folks. For example, if you take your first break schizophrenics, 78% have had marijuana use or dependence within 4 years prior to that diagnosis, compared to something like 30% of controls. So there's no doubt that there's a link between cannabis use dependence and the development of a permanent psychotic disorder. And again, the one clue, like if a young person does marijuana for the first time and gets paranoid and hallucinates, that is not the individual who needs to be doing this garbage. So if the first warning signs of psychosis, that should be send them running out the door. And we also know, just to confirm sort of the genetics, that in relatives of schizophrenics, they're more prone to have, adult relatives of schizophrenics are more prone to have psychotic symptoms from using marijuana. And they're out of the danger zone generally of the presentation of schizophrenia. But again, there's just something genetic going on there. So it's a great question.
Have you noticed problems with pseudoephedrine abuse and how this affects one's brain?
Yeah, that's basically, it's an amphetamine derivative, and it's a precursor of an amphetamine makes that compound. So people can take the pseudophed type compounds and sort of reverse engineer them to more potent amphetamines. In general, they're the abusers of that in general are the ones I worry about are the bipolars, where they use it to jack themselves up or to get more ill. But it's more the methamphetamine and more pure stimulant abusers that run into more trouble, that have, like, for example, we were talking about the risk of cannabis dependent leading schizophrenia. Amphetamine dependent and abuse in 33% of people of those that are high dose abusers will develop schizophrenia. So yes, but we do see some over-the-counter stimulant abuse, the cold meds and so forth, but they've gotten more restrictive about selling them, and people have found they get more bang for their buck with the more potent stimulants.
Okay, this is the last question for this section of the Q&A. How did the cocaine compound go from non-addictive 50 years ago to the addictive drug it is today?
We're talking about the cocaine? Is that the
Yes.
question related to cocaine? Yeah. Well, cocaine's always been addictive. Yeah, it's always been addictive. And again, it's one of those fast on, fast off receptor agents that induces cravings of itself. I don't know what they're referring to in the sense that there may have been less potency, and a lot of people find the crack form more addicting. Maybe that's what they're referring to. And again, it's about a potency and a concentration issue rather than the cocaine molecule itself. Okay, you want me to hit slide 24?
Yes, please.
Great. Okay, well, this is methamphetamine. And meth, of course, we have a lot of trouble with meth abuse and violence and criminality and so forth. But you may be interested to learn that it was actually synthesized in the late 1800s. The first amphetamine was made in 1887 by a German chemist, and shortly thereafter, methamphetamine was made by a Japanese chemist in 1893. It has an interesting history. In World War II, the Germans and Nazis were giving it to their mainly their Panzer divisions and the Luftwaffe pilots, and they thought it kept them alert and awake. Of course, thought it enhanced performance, and the troops actually called it Stuka tablets or boring pills, right, for the Luftwaffe. And curiously, the American military experimented with it in pilots who were flying in the Pacific over long missions. They realized, though, that the problem was that these gentlemen have trouble controlling their aggression when they were on it. So they switched to dexedrine or dextroamphetamine for those pilots, whereas apparently the Nazis did not have a problem worrying about the over-aggressiveness. That seemed to be just fine, I guess. But interesting that it was sort of widespread in the German military at one time. But at any rate, so the acute abuse does give people agitation, anxiety, euphoria, volatility, and of course there can be a psychosis. And many of these people, are antisocial at baseline. It's very hard to keep them. Usually it's something like a court order that gets them in the hospital or some event out of their control. They usually don't come into treatment on their own. We don't really have a specific detox for methamphetamine, but we do use a lot of anti-manic, antipsychotic agents because these people tend to be prone to violence. They tend to be hyperactive and agitated. So we may use some phenobarbital. Slide 25 just talks about the chronic effects, and you've seen the sort of the effects on the commercials of people where they get this self-neglect and their faces deteriorate, their teeth deteriorate, and so forth. But there's a high suicide rate, cardiac disease, violence, and even again this permanent psychosis from methamphetamine use. And the methamphetamine itself is not thought to be directly toxic to neurons, but it's through this sort of hyper-release of dopamine, which over the dopamine in excess quantities is neurotoxic. And also, that's why many of these folks over time develop Parkinson's disease. They've got a disease of dopamine depletion and dopamine dysregulation. And again, 2 out of 10 of the methamphetamine abusers will develop a permanent psychosis. Where it doesn't always look like schizophrenia, but it's close. They're chronically disorganized, delusional, and so forth. So coming to slide 26, we've talked about the opiates briefly and the narcotics, and you see all the different forms up there. And of course, it's a very common problem, and it's neck and neck with motor vehicle accidents as far as the number one reason for accidental deaths in the U.S. People are taking too much heroin, too many opiates, and in particular, if they take it with benzodiazepine, like a Xanax or a Valium or an Ativan, the two together will suppress breathing. And what we run into is that these patients, they enjoy the euphoria, they get pain relief. Some people find it energizing. And if they've been taking it for any sort of chronic pain condition, when they stop or decrease the dose, they get what we call rebound pain. So that somebody may have been prescribed OxyContin for a back condition or something like that, and they take it for 4 to 6 months. The attempts to taper it or discontinue it are very difficult simply because the chronic opiate use has upregulated that opiate receptor, right? So that now, what happens is the pain comes back more severe than it was before they ever took the drug. And what they've got is a situation of what we call rebound pain. And so they begin to take more of the drug just to dampen the rebound pain that the drug has induced. And now their primary pain just keeps going higher and higher. And that's why they find it. I meet so many young folks who say, well, I just can't get off it. The pain has gotten so severe. So that's why it's always better to use non-opiate measures for chronic pain. I think if somebody needs relief after surgery or has cancer, sure, that's what these drugs are for. But of course, long-term, we don't think they're a good idea. And as I mentioned in one of those bullet points, so they get a tolerance that gets higher and higher. So the amount they need to feel the pain relief or feel a high gets higher and higher. But the lethal amount, the amount that stops your breathing, does not change. That does not go higher, so we see lots of accidental overdose as a result. Now, when you go through withdrawal, the withdrawal from opiates, there's no seizure. There will not be a seizure, but these people are terribly irritable, uncomfortable, agitated. They have cramping, GI upset, sweating, the nausea, vomiting, and they just feel god-awful. And I tell them there's not one magic bullet, but we'll give you as smooth a landing as we can. We either use a phenobarbital protocol or we use a clonazepam protocol, which tapers down, and we add a muscle relaxant. We add something for the GI upset, something for the sweat sometimes. And, sometimes we use Neurontin, gabapentin, topiramate for the anxiety and chronic pain. So that's another issue. I've had many patients with chronic pain, and their opiate use has gotten out of control. Maybe they've been buying it off the street. And so we've detoxed them successfully, and they're standing there saying, okay, what are you going to do about my pain? I don't want to go out and relapse. So we send them to a good pain clinic that uses non-opiate measures and physical therapy and so forth. And as you know, that the reason the heroin use has gotten so high is that doctors have gotten very reluctant to prescribe opiates because of the pill mills and so forth. There were certain counties in Florida where something like 80% of the opiates written were sold on the street, and that was just what they could detect. There was a certain county in West Virginia where there were more prescriptions for opiates than people actually lived in that county, So it just doesn't make a lot of sense. It's obvious what's going on there. And so there's a tremendous street value with these, and as the law enforcement come down from all directions, and doctors are more and more aware of this. We have the Controlled Substance Data Bank in North Carolina where I can look up and see where people have filled what prescriptions and who they're getting them from and so forth. But the heroin has become the alternative for many of these individuals. So that gets us to the methadone and buprenorphine on slide 27. So the idea behind methadone was to say, okay, you're on heroin and you're injecting, the needles are bad, you're going to give yourself the disease, and why don't you come to the methadone clinic and we will get you on a legal option and taper it down slowly. And the buprenorphine or Suboxone is the latest of that version, where it can be a maintenance therapy or a tapering off therapy. And some people use them for acute detox, but most of the time they're used for continued therapy. So this philosophy is one that I don't agree with, but some of my colleagues do. I don't accept that there are some people that just simply have to be on a Schedule II compound. For example, we detoxed an 18-year-old girl who'd been on heroin for 4 months, and I detoxed her, got her completely clean. When she left our facility, she was on no drugs, and a colleague of mine in another town, not too far away, had a very similar patient who'd been a heroin addict for actually 3.5 months, same age, same demographics. He put on Suboxone. I said, why are you doing this? Now you just got her addicted to something else. And he felt like she would be less likely to relapse and so forth. So again, there's a big split in our communities whether this is even a good idea or not. And I can tell you that for every one person that he thinks is a good idea for, I can admit 10 or 12 that have Suboxone in the system, but also have cocaine and Xanax and marijuana. So to me, I being a hospitalist, I don't see the people who are out in the community where it's quote working. I only see the train wrecks, so maybe that's tainted my view. So at any rate, and again, I think that if somebody's on one of these propepidone or Suboxone programs and they come in with cocaine in their system, I think they're not a candidate. But some people do use it as a detox measure. So that's buprenorphine is in more detail on slide 28. So when you hear about Suboxone and buprenorphine, the idea is a partial agonist at the receptor. Now, what's a partial agonist at the opiate receptor? If a neurotransmitter or a drug or a ligand hits a receptor, it sends a signal inside that cell and things happen inside that cell. But you can have what we call a partial agonist where it's only 40 or 50% or maybe 60% as effective, or that signaling is dampened. Okay, so that's the idea behind buprenorphine. It's going to be more potent and have a longer duration, but it's not going to be a full agonist. So the idea that they could harm themselves or become more addicted was sort of the promise with a partial agonist. So again, it's a philosophy that you have to buy into the chemistry too. May not have explained that well, because you can use lower amounts. Morphine is more potent and has a longer duration on the receptor, stays on there longer, so there's less withdrawal. But again, it's not a full agonist. It has a high affinity, but not a full agonist. And so therefore, lower activity is described. So that's, again, a bit of a confusing bit of science there, and you can tell where my bias is on that. So slide 29 talks about 2 cases. Both these individuals were in the hospital. The first one was a 63-year-old gentleman who came in with, basically, I think he was even there for a minor surgical procedure, and he had a negative drug screen on addiction. But within 14 hours, he went into a generalized seizure, given Ativan, and wound up in the ICU when we were asked to see him. Another individual came to my floor. He said, get me off of these pain pills. Drug screen showed the opiates and marijuana. He was given a catapress detox. We use that sometimes for opiate detox, and some muscle relaxants and so forth. Within 3 days, he was hallucinating, became disorganized, had to be restrained, secluded, so forth, required IM antipsychotics. So what is the drug that both of these individuals did not have in their drug screen but were on? And of course, slide 30 is asking that question. Neither patient revealed their other drug of abuse. What was that drug? So slide 31 is Xanax, alprazolam. Xanax is notorious for this. It's a short half-life agent, so somebody may stop it. It's not in their drug screen after a little while, so they come in 24, 34 hours later. It's not in their drug screen. But if they've been addicted to it, if they've been taking 3, 4, 5, maybe 8 milligrams a day for several months to years, then they come off it. they will hallucinate, they will have seizures, they have a terrible time. So it's very hard to detox them. And again, that's the only time you really feel sucker punched as a clinician, when somebody doesn't tell you they've been using Xanax and you're detoxing them for the wrong thing. Yes, it works for anxiety. So if somebody has a panic attack or somebody needs to get through a funeral of a loved one, we give them Xanax. But we try very hard not to give it long term for the highly addictive nature, the highly abusable nature of it, and the cravings. Just like that cocaine story, there are changes in the GABA receptors after one dose of Xanax, so that the body wants more of it. The best way to detox someone off Xanax is not with Xanax, because you're always chasing your tail there. It's best to use clonazepam, which hits the same receptors but has a much longer half-life, and carbamazepine, which has two roles. That's Tegretol, so it can have an anti-seizure effect, but can also block some of the physical symptoms of Xanax withdrawal. But we don't use the short-acting benzodiazepine like lorazepam. And even phenobarbital, even though it hits a lot of receptors and it's kind of a standard detox measure and has anticonvulsive properties, patients who are addicted to Xanax will still have a seizure despite phenobarb detox. And when is it okay not to detox somebody? If grandmother has been on Xanax for 20 years, I don't stop it. You know, if somebody is over age 65 and the Xanax has been on board for over 4 years, I simply find it unwise to detox them, because there's no, as we age, our receptor plasticity is less. We don't upregulate or downregulate as quickly. And sometimes you can pull the rug out from under people. You take away that alprazolam, take away that Xanax, and Humpty Dumpty is broken, and they're highly anxious and agitated and nervous, and reintroducing it does not fix the problem. So there's a point of no return, and it's really one of, just clinical judgment. Okay, so slide 32 is fun. This is Arthur, our favorite alcoholic, leaning out of the car, making interesting comments to the young ladies. So you may remember that movie. And of course, if you think about, alcoholism, and you think about the amount of humor and shtick that goes into that, the fact that in a funny sort of way, some alcoholics are rewarded for their entertainment value. We have comedians who the Red Skelton type, or Foster Brooks, or even Dean Martin, who made a whole career out of that quasi-intoxicated or intoxicated demeanor. And if you think about the clown itself, the clown is nothing but a caricature of the alcoholic. He's got the middle-aged gut, he's got the floppy shoes that make him have an ataxic gait, he's got the bulbous red nose, he's got the painted-on smile while the tears are coming down. So, so everything about the clown is actually a caricature of the alcoholic. Anyway, so we'll talk a bit about alcohol. And my favorite two quotes are slide 33, Churchill saying, "I've taken more out of alcohol than alcohol has taken out of me." And of course, slide the second one, "A life without alcohol is like driving a race car without motor oil." That was a famous Hemingway quote. He made that quote when his doctor told him to cut down to 2 glasses of light red wine a day. And that was in Cuba. He had a Cuban doctor tell him that if you keep drinking like this, you won't be able to write your own name. And he also was prescribed Secanol, so there was a period in Cuba where he would be drinking and taking sleeping pills that were barbiturate, and he was tending to fall asleep on his guests. So slide 34 shows the young Hemingway in his World War I uniform, and the older Hemingway there, the famous Karsh photo. And the upper right shows Zeldin Scott Fitzgerald, and of course Fitzgerald in the bottom right. So it's just amazing when you think about the genius that's shown in that slide, and yet the destructive effects of alcohol on these geniuses. Fitzgerald dying in his 40s from a heart attack, but of course he was a severe alcoholic. And of course his wife Zelda was schizophrenic, probably schizoaffective bipolar type, but the biographies generally describe her as a schizophrenic. And there's a famous letter that he wrote to friends saying that people say that she's crazy because I drink, and I drink because she's crazy. So, but neither are true, he said. But it's just amazing that when you think about the whole lost generation of writers who went to Paris, by the way, due to prohibition, and the amount of mental illness and substance abuse in that group. So 35 is slide 35. Yes, 2 glasses of wine, good for your heart, no problem. When alcohol becomes a problem is when, according to DSM-5, there's functional impairment, and there's withdrawal symptoms without it. We know the lab findings. There's elevated liver enzymes. But contrary to popular belief, most alcoholics will develop some degree of alcoholic hepatitis. In the more severe cases, we'll have hepatitis C on top of that. That's some of the very high liver enzymes we see. But only 15% of chronic alcoholics will develop cirrhosis, so that's fairly rare. Most people think it's common, but it's fairly rare. That's literal scarring. It's much more common to have inflammation or hepatitis than it is to have the scarring. And yes, chronic alcoholism will lead to a form of dementia. Looks like Alzheimer's. So you can have alcoholic dementia. You can have mixed dementia. So a patient can have we'll go into our next series on dementia. So we detox alcoholics with a variety of things. Most centers use Librium or Valium, because Valium breaks down to Librium. But that's a long-acting benzodiazepine, has anticonvulsant properties. It's important to replenish thiamine, because thiamine, the B1 vitamin, is very important for memory functioning, and most chronic alcoholics will be depleted in thiamine. There's evidence that they reduce the risk of seizures in alcohol withdrawal. And sometimes we'll use phenobarbital. For example, if someone comes in on alcohol and Xanax or alcohol and Klonopin, that's a special regimen. We might use phenobarb, we might use clonazepam and Tegretol for that. Someone comes in on alcohol and pain pills, we would probably use phenobarbital. Alcohol and cocaine, we probably use an alcohol detox protocol with something for cocaine cravings. Two other points. When I was a young resident, I was moonlighting in a hospital not too far away, and I had an alcoholic I was detoxing, and he was just off the chain, psychotic, delirious, had frank DPs, and I was doing everything right. I was giving him the right detox regimen, giving him antipsychotic, thiamine, everything I could think of, even magnesium that might, be helpful. And I just couldn't figure out what I was doing wrong, and I did enough reading to realize that 10%, 1 out of 10 alcoholics will remain delirious despite adequate detox. They still go through DT. So just file that away. And when do you detox someone? There are many people many alcoholics that can kind of stop and start on their own, and they don't have significant withdrawal. And all I can say is every body is different. Every human being is different. If their blood alcohol level is 200 or under, we tend to say it's okay to do an outpatient detox, but that's very hard to do, to give somebody a set of prescriptions to get them off of a drug. It's very hard to do that. We tend to like to do it in the hospital, because if they're left to their own devices and they don't have a family member supervised, it's very hard to stay clean and sober. If the blood alcohol level is over 400, you usually go into the medical bed, not the psychiatric floor. The highest blood alcohol level on record is 1,500. I kid you not. Most people are in a coma at 600, but this individual walked into a California emergency room, stated he was there for detox. They checked his level, and before they could come back to him, he just changed his mind and walked out. He was never found again. But 1,500, if you can imagine that. So the last bullet point, are benzodiazepines always contraindicated? What I mean by that is, I had an attending as a resident who had no problem giving an alcoholic Valium. And he said, if I give this guy Valium 10 milligrams 3 times a day, he doesn't drink. And his liver's going to survive, and that's that. Again, interesting philosophy, and it's a fine philosophy if it works. If it doesn't work, of course, now you've got 2 compounds on board. So that's a whirlwind tour of alcoholism. I know we're towards, you guys there still?
Yes, we are.
I think I got you. Oh, great. Okay, I heard some funny noises. Okay, the last few slides, slide 36, is one of my favorite movies, Blue Velvet, and you may remember this from the 80s. The director, David Lynch, was nominated for Best Director. It's been called the first American surreal movie, and it had Dennis Hopper, of course, Isabella Rossellini. The critics were pretty split on it. Some people thought it was just gratuitous and it was unfortunate, and that Isabella was just, made to do things that were not pleasant and so forth. It came out in 1986, if I remember right. But the reason I show it is, remember the Dennis Hopper character was a nitrous oxide inhaler. So he was getting high on the sort of a laughing gas kind of thing. So there are people that have used inhalants. There was in the one script, I think, an early version was using nitrous oxide, which is, different than amyl nitrate. So there's some people that say it was amyl nitrate, but the tube indicates it would be nitrous oxide, like the dentist would use, basically. But the amyl nitrate people have abused as an inhalant because, believe it or not, it is thought to enhance sexual activity. So, truth or not. So, slide 37. The inhalants are any sort of compound, like the glues and we have one patient that tends to go after the spray cans to clean your computer and so forth. So the problem with these is that it's like that New York hot dog. You really never know what's in it because there are a lot of other chemicals within those compounds that people are inhaling that can be neurotoxic or can have hallucinogen effects, and sometimes the high is just from inhaling this solvent and at the expense of inhaling oxygen, so people get a little loopy on that. So again, there's not one type of inhalant, there's any number of them. Fortunately, there's not a lot of PCP use now. Over-the-counter meds, you mentioned the stimulant use, the cold meds. Believe it or not, dextromethorphan is actually a hallucinogen in the brain if it's not broken down. And patients who are on fluoxetine, Prozac, right? Prozac will prevent the breakdown of dextromethorphan. And so that has been used as a combination of people who wanted to hallucinate of all things. So again, all these bizarre things. And fentanyl patches, the idea behind the fentanyl patch is here's a way of providing pain relief in a way that people are not supposed to be able to abuse it because it's in a patch. And patients have learned that they can chew the patches. They've also learned that they can hang them on the clothesline, let the sun melt the medicine out, and then they can let them drop into their mouth. So that's called the fentanyl syndrome. So again, all this energy to be deranged, some of us don't understand. So slide 38, the last few, all this talk about abusable meds, and some of them are prescription meds. Well, how do we make our chart okay? How do we make sure we're doing the right thing by the patient? So, for example, the person I told you about, the attending who said he doesn't have a problem giving alcoholic Valium. Well, first of all, do you have a diagnosis that justifies the use of that compound? Do they have generalized anxiety disorder? Do they have something that would justify the use of that compound? Have you tried something safer? Did you try buspirone or hydroxyzine or gabapentin or one of the non-addicting options out there? Are there toxic behaviors? Is the person calling because somebody, they flushed their prescription accidentally or somebody stole it for the third time this week? So if there are no toxic behavior like driving impaired, and you have a third party, the wife comes in and says, yep, he takes it just like you write it, there's no problem there. Then if those four criteria are met, then it's generally, you're in safe legal territory to continue a Schedule II drug in somebody that you may have concerns about. Slide 39, it just speaks to the petition for involuntary commitment. As you know, in all 50 states, an individual can be hospitalized against their will. The police and emergency, they can actually take out an emergency form without going to a magistrate having it notarized if it's that acute. For example, the psychotic individual I mentioned today, the police just brought. But you have to be not only mentally ill and or a substance abuser, but you have to be acutely dangerous. So the potential for dangerousness is not enough. We had a petition last week, a young lady's parents petitioned her because she likes to abuse drugs. She said, yep, I'm not going to stop. I like to use these drugs, and you can detox me, but I'm going to go out and buy more cocaine, marijuana, and pain pills. And I don't want to kill myself. I never wanted to kill myself. I just like using these drugs, and you can't stop me. She wasn't psychotic. She wasn't suffering from any depression. There was nothing. So I explained to her parents that unfortunately she did not meet the legal criteria to hold her against her will. As sad as it is, I would have loved to have said, too bad, you're here, but legally we just could not hold her. So just so you know that's often a disappointment, and we all have our horror stories of patients we knew should have been in the hospital, but just legally we could not do anything about it. Slide 40 was an interesting case of a young lady, very young, I think 48, who had alcoholic dementia. That's very young to have alcoholic dementia. And she was in very vulnerable situations, giving away her money, running around with people, but her short-term memory was so bad and that she was getting into terrible situations, and her daughters had to take over guardianship. So again, I just throw that in because here are these daughters in their 20s had to take over guardianship for a mother So the roles got reversed much sooner than they should have been. But there are tremendous vulnerabilities. And why this young lady developed alcoholic dementia and another one didn't, who might have had a similar drinking pattern, we just don't know. The genetic risk is still trying to discern that. We have some theories, anyway. So we all have this issue in medicine. Recently, there's been a gentleman we had to dismiss from the clinic. He was getting alprazolam from our clinic and two others. We found that in the data bank. So we have to, of course, offer him detox. Say this is the real problem with substance use. We document what we're doing. But again, the medical boards are coming down very hard on people who are aware of these situations and don't take action. So, we've all been fooled here or there, but once you are aware that there's a problem, you really must offer the patient detox, cut off their supply, and despite how unpleasant it may be or how much you get threatened and so forth. So let's see if there's any. Oh, there we are, the last Q&A, Nadia, so I think we're on time, so given our glitches. Okay, you still there, Nadia? Yep.
Yes, I am. Did you conclude your slide?
Great. We are there. I'm at slide 42. Terrific.
Awesome. Okay, so if all the attendees could put in the passcode this last time, we have two questions that I'm going to ask. The one, since the 12-step programs were written in the 1930s, and in my opinion, society has moved away from overt religious affiliation to more general spirituality. Do you see a benefit to a new text which emphasizes new science?
Well, I do. What that looks like now, we just don't know. We know that the 12-step model, you're right, it's very old and it works for a subset of people. If you're not that kind of person who wants to sit in a meeting and talk to other people, it's a social therapy that works for a certain personality and a certain person. It's not for everybody. That being said, it's still the most successful thing we have. What is the new one like? It's got to be some combination of motivational interviewing on our part, where as we interview people, we're motivating them towards the recovery, and it's sort of a whole idea of that seems to have some success with chemical dependency, and some type of spirituality. I think because, again, the chemical dependency is it's an illness of lack of control. And patients will tell me they're actually propelled into this almost subconsciously. They just do it, and they don't know why. They don't always have an explanation. I think it was interesting. I had another patient. What saved him was becoming a follower of the Mehar Baba, right? So an Indian guru. So I think for him it was highly individualized. He found a different spiritual guru that sort of kept him drug-free. And the controversy, too, with the AA-NA model is that it takes so much effort and energy to keep you away from something that something still controls you. That's the other controversy there, is you're spending so much time with meetings and in the world of recovery that you're addicted to something else, and the criticism. Again, I don't know that I would state it that way or agree with that, but I just want you to know that it's not a one-size-fits-all. It works for a certain personality style. And what the future looks like, I don't know. I think it's going to be some combination of motivational interviewing, cognitive behavioral therapy, and some type of chemical issue to keep away cravings or to reduce desire. But very, very tough. And again, we don't have the answer. We really don't. It's just an illness of relapse.
Okay, and the last question is, what is the relapse rate for opiate addiction?
Right, well, it's very high. In that one study I mentioned, within 6 months, 90% had relapsed, and over 50% had relapsed within the first week of being released. So it's it's an illness of relapse. And it's just sad the way it is now, because, again, those dangers of the lethal dose being there while the tolerance goes up, it's just the social decline these folks have, the disruption to families is very tough. So does anybody have an easy question, Naja?
Well, that was the last question, Dr. Farah, and you did an awesome job.
All right. Oh, you're very kind. Well, thank you all for joining us. Yeah.
Yes, I actually did want to thank everyone for, sticking it out with us through our technical difficulties. I will be sending around the follow-up email, and in that email I will provide a promo code that you can use for expert witness referral services, just one expert, one time. In addition to being your best source for testifying and consulting experts for the past 60 years, TASA also offers e-discovery and forensic solutions, free interactive webinars like this one, cybersecurity services, day-in-the-life videos, in addition to research reports on expert witnesses like the Challenge History Report 2.0, Professional Sanction Search, and the Expert Profile 360. Thank you, Dr. Farah, for all of your time and for actually sticking it out with us as well for the technical difficulties. If you guys would like to speak with Dr. Farah or any TASA representative, feel free to give us a call at 1-800-523-2319. My colleague Tom Masucci was sitting in on the webinar with us today, and he will be giving you all a call to follow up with you on your feedback with regard to this presentation. Just as a side note, Dr. Farah is presenting a webinar next week on dementia and modern legal practice, which will be April 14th at 2 p.m. Feel free to register from our website, and the link will also be included in the follow-up email that I will send out tomorrow morning. Thanks again for joining us, and this concludes our program.
Great. Thank you.